start the session. This is about a 4-year-old male child who was brought to the hospital with complaint of fever, cough and cold for past 2 days, and this included workout breathing for the past 12 hours. So mainly fever, cough, cold, and included workout breathing, short duration of history. This is the initial assessment triangle in the emergency room. Child was quite irritable, so there is included workout breathing with the normal peripheries. So what are the interpretation and intervention we want to do at this point?
No.
Yeah, we have to move on. So what we have to do at this point? It's unstable life-threatening condition, so we have to start him on oxygen and into workout breathing, and you can ask for an IV access because this child can collapse anytime. So we need to move on to primary assessment. So primary assessment, airways maintainable. So breathing wise is a tachypnea, nasal flaring, severe wheeze was there, marked retractions was there, and his SATs are around 82% on room air with O2 it was improving to 90%. Circulation wise, there's a tachycardia, otherwise the others are stable. So the disability was 14/15, airways is okay, exposure is normal. So what we have identified here and what is the intervention we have to plan here? So from the primary assessment, so what stage the child is now? Respiratory wise?
So start on palpable embolization.
No, what stage? What is the classification of respiratory problem here? So first you have to identify, right? We have evaluated the child. You need to identify what is the issue now. Then we have to intervene. What is the identification here? So most likely child is moving towards respiratory failure with some irritability and GCS was 14. So some secondary cerebral dysfunction because of the hypoxia. So what intervention we can plan here? Already we started on oxygen. So what we can do here?
As there is wheeze, we can start on
Okay.
nebulizations.
Because of the wheeze, we thought we start on nebulization. Fine. So the next question comes here is what are the causes of wheeze in a 4-year-old child? Or what are the DDs you want to keep in this child? With this history and examination findings, what are the DDs you want to keep in this child? Yeah, this I'm not asking any. Always a basic questions only. Yeah.
History of fever is there, sir. So probable viral induced wheeze.
Yeah. Viral wheeze is first possibility. 100% accepted. Next. Next. That's the only no respiratory causes of wheeze. Any other cause of wheeze is there?
Bronchiolitis, bronchopneumonia.
Bronchiolitis for a 4-year, yeah, very less. Yeah, bronchopneumonia is one possibility. So more than 2 years, the bronchiolitis term we have to use for viral wheeze. So ideally it's applicable less than 2 years only, bronchiolitis. So any other organs causing wheeze apart from your respiratory?
Laryngotracy, laryngomalacia.
Yeah, not laryngo exactly. Your tracheobronchomalacia can cause. Apart from the parenchymal, you are asking about airway, apart airway like infection and inflammation. The third thing is structural anomalies. It all comes under lung only. I'm talking about extra lung causes of wheeze.
Extrinsic compression by any external mass on trachea can cause wheeze.
Okay. Compression lower part of trachea. Most are strided than wheeze. Tracheal compression will cause. And if we have extrinsic compression bronchus also, it will be unilateral wheeze, not bilateral wheeze. What is cardiac wheeze?
In congestive cardiac failure, sir.
So always think about other cause of wheeze also. When don't blindly jump and treat for, because I have seen many infants with viral myocarditis coming with extensive wheeze. So treating as bronchiolitis. And the moment we start nebulization, they'll worsen. Even without Krebs, they can have only wheeze. That is called cardiac wheeze. Even in pulmonary edema, it can cause compression on the small bronchioles and it can induce the wheeze. You can in that extensive wheeze, you cannot even find out Krebs. So never forget to rule out cardiac causes. So in this child, how to rule out is a cardiac pathology is there or not before starting nebulizations? Because his heart rate was around 150. His heart rate was 150. So how to quickly rule out cardiac if we are not dealing with cardiac? I'm asking a basic question. How to rule out CCF?
Clinically hepatomegaly, sir, and any murmur or gallop, and BP wise, if there is any narrow pulse pressure.
Yeah, fine. So you are looking for signs of CCF. So majority like hepatomegaly. The problem with VG children is they will have obviously they will have enlarged push down liver. So it's very difficult to differentiate whether it is a push down liver or it is an enlargement because of the hepatomegaly due to CCF. So always check for a span. Liver span is must in all this kind of children, and never forget that thing. Just a very palpable liver is not hepatomegaly in VG children. So we can have organomegaly, push down liver and spleen also. So look for JVP. It is a 4-year child, so we can obviously look for a JVP. Krebs, predominant Krebs. If you have find some amount of Krebs also, the older children, please think and look for cardiac cause. And if you have obviously murmurs, gallop, then definitely you need to certainly rule out cardiac conditions. The other DDs for here is like viral wheeze, and it could be an asthma. It's not simple viral wheeze. It's a asthma, exertion of asthma triggered by your viral infection. Viral infection could be a trigger for asthma exacerbation. So when you want to proceed to secondary examination, secondary assessment, so what are all things you want to ask for and look for to identify whether we're dealing with asthma or not? So at this stage, we're at the primary assessment. So we have some DDs. When we quickly move on to secondary assessment. So once you move on to secondary assessment, what are the things you need to focus to make sure that we are dealing with an asthma?
Past history of any wheeze, and whether child is on any medications, any history of atopy, family history of atopy or asthma.
Good.
Any food allergies.
Good. Any other thing?
History of atopy.
Yeah, absolutely correct. Strong past history of similar episodes. Most importantly, they should have relief with bronchodilation.
That is,
So the majority of the time, the infants will have bronchiolitis, but you don't get that much relief with bronchodilators. So Mary per se bronchiolitis in the past history will not be sufficient to tell they will have likely asthma. So you need to make sure that it is not simple bronchiolitis, it is a viral wheeze or a hyperactive airway disease, which is getting relief with bronchodilator. That's the most important history to ask. And personal history of atopy, it could be allergic rhinitis, or atopic dermatitis, or food allergies. And strong family history of asthma or any allergic rhinitis is one more predictor. And most importantly, if the child had a wheeze without any fever or cold, let's say without any viral trigger, so it's very unlikely to be viral wheeze. So it points towards asthma. And any symptoms which is pertaining to your exercise and activity, it's almost like 100% pointing towards asthma. So these are the things we need to ask and focus in an examination as well. You have to look for turbid hypertrophy, cobblestoning of the posterior pharynx, and allergic symptoms like blackness around the eyes. So these are the things we need to commonly focus when you're examining a suspect asthma child. Next thing is any indices to predict asthma development in future, which can help in your acute management suspicion of asthma as well. Is there any indices which is proven already and which has been widely used to predict asthma in the younger children? Can anyone name the indices? And once you tell it is an asthma exacerbation, and what are the scores available to manage these children in ER and the PICU? So once you label this asthma exacerbation, then what are the score you can do, which can guide us in the management? The first question is, what are the indices to predict asthma development in future? Are there any indices? Anyone knows the indices? So this is one indices which can use commonly. Previously, is asthma predictive index. Now it has modified asthma predictive index, and you have to use this in less than 3 years children. And what other things you have to look for is in the past 12 months, if you have more than 3 episodes of wheezing. So you should have more than 3 episodes of wheezing in the past 12 months. That's the first important criteria. If that is not there, you cannot move on to the major environmental criteria. If the first one is satisfied, that is more than 3 episodes, or that is at least 4 episodes in the past 12 months, then you can move on to the major and minor criteria. And at least we should have 1 major and 2 minor criteria to satisfy. This is more for the future asthma. So the major criterion, the first thing is parental history of asthma. Like this factors we have assessed previously, the same things are incorporated here. The parental history of asthma, and second thing is physician diagnosed atopic dermatitis in the child. Child should have atopic dermatitis, and if you have either skin prick testing or immunocap to check IgE for any aeroallergen. Aeroallergens are like house dust mite, pollens, moles, and danders. So these are the common aeroallergens, and at least you should have sensitization for at least one. Either your skin prick test is positive for one aeroallergen, or your immunocap is showing high levels of IgE against one specific aeroallergen. These are the 3 major criteria. You need one for among them. And in minor criterion, you should have wheeze unrelated to colds. So you should not have a viral prodrome while child is wheezing, or if blood eosinophil counts are more than 4%, we suggest child is having tendency towards allergy, and any food allergy. Child sensitization towards food allergens, not aeroallergens. So food allergens is a minor criterion. So these are the criteria we have to use for, and you can predict future occurrence of asthma. And even when you have doubtful, when you are treating a viral wheeze child, whether you need to treat it as a simple viral wheeze or you have to treat it as like a hyperreactive thing which can later proceed to asthma, whether to add steroids or not. This criteria will help. So our child has parallel history of asthma, child had past history of atopic dermatitis, and child also had past history of like 4 episodes in the last 12 months needing nebulization, is a good response to nebulization, and the child had also wheezing unrelated to colds. So most likely our child is, we are dealing with an future asthma child, and this current episode also can be hyperreactive thing. So if you have negative, this index is negative, then you can the most that it can tell a negative predictive value like more than 95%, they will not develop asthma in the future. So that is the importance of asthma predictive index. Whenever you see any child in less than 3 years with recurrent episodes of wheezing, I think we should evaluate this child for a future risk of asthma. So that is what first thing I want to suggest from this slide. And next thing is pediatric asthma score. It is acute scoring in the ER. It has 5 components. One is the respiratory rate and breath sounds, wheezing, accessory muscle usage. There are different asthma scores available. One PGI developed some scoring, AIMS developed some scoring, IAP has some scoring, UK has some scoring, US has some scoring. But this is what commonly followed. You can choose any scoring for your unit. It's not a mandate to use only one scoring. So it's the ease of usage. That's what the most important thing is. And this is what this is component. And you have to assess. You have to use score 1, 2, 3 based on the severity. And so based on the scoring, you can label them as mild asthma, moderate asthma, and severe asthma. And based on this scoring, our child score comes at 13 to 14. So it is in severe asthma situation. And what is the role of this scoring? This role of scoring is very important when to assess the response to your treatment, and what level the child was at the presentation, and what level therapy you have to give, and what is the response to your treatment. All things can be guided by your asthma score. So always make sure your habit of scoring asthma severity in the ER itself, at the arrival itself. Based on that, you have to decide your treatment. If it comes to mild, moderate, then the treatment is different. And if it's moderate to severe asthma, the treatment is different. So make sure the habit of scoring these things in the ER itself. And most importantly, you have to keep monitoring at regular intervals. You have to keep scoring at regular intervals to see the response of your treatment.
Hello.
So the next question comes is, what are the initial bronchodilators in mild to moderate versus severe exacerbation of asthma? Is there any difference? So what commonly you start when you want to start nebulization for this child? Please, others can mute themselves. Who is not talking? Kitna, just see and you can mute them. So mild to moderate, it is only salbutamol, and in severe exacerbation, you need to combine salbutamol with ipratropium at the A head itself. So never start only salbutamol for a severe exacerbation of asthma. You need to combine with ipratropium. You can straight away start duoling in the ER itself. And how to give this nebulization in the ER?
The oxygen.
Yeah, with oxygen. And how will you give? How many times you give? How much you would have to give?
150 mg per
Is there any dosage?
So, ipratropium we can give 250 micrograms 3 times 20 minutes apart, 3 doses. And salbutamol 0.1 mg per kg. That also we can give 3 doses 20 minutes apart. Or we can give continuous salbutamol nebulization also at a dose of 0.1 mg per kg per hour.
Yeah. So the dosing is clear, and I think everyone will have almost in the dosing charts or something in the ER. And either you can go for this mg per kg dosage, or simply if you don't know confusion, less than 20 kg, go for 2.5 mg, and more than 20 kg, 5 mg. That's all. It's a very simple number you can remember. So less than 20 kg, 2.5, more than 20 kg, 5 mg. So no need to have confusion about dosage. And the minimum dose should be 2.5. You cannot go below 2.5 mg. 1.25 mg will not work. So never go below the doses of 2.5 mg. Even for if you're given for infants, the dose will not go down. So remember this, and you have to give it over 20 minutes. Each dose you have to give over 20 minutes, and you have to give at least 3 doses in the first 1 hour. And depending on the response, you have to decrease the frequency, or you have to go for continuous nebulization. And if the child is already on MDI, that immediate dose inhalers, you can try giving puffs, 4 to 10 puffs, depending on the age of the child. Same thing, 20 minutes, and you can repeat it again, 3 doses. So ipratropium is same. So 250 micrograms for less than 20 kg, and more than 20 kg, 500 micrograms. So it's simple. So remember, doses of salbutamol, ipratropium, there should be no confusion in this. And you can give 3 doses in 1 hour, and again we can repeat every 4 to 6 hours depending on the need. If you are giving MDS, give over 4 to 8 puffs. So anything you have to repeat twice in 1 hour. So the next question comes here is, what is the difference between nebulization and MDI in acute asthma treatment? Whether nebulization has advantage over MDI, or MDI has advantage of nebulization, which is the most preferential mode in the current era of MDI usage. So nebulization versus MDI in acute asthma treatment. Yeah, we have to move. Both are same. Nebulization is more superior than MDI, or MDI is more superior than nebulization. What is the physiology behind this nebulization and MDI? The first question is, which will have more deposition of drug in the respiratory tract, nebulization or MDI?
MDI.
So there's no doubt in this, right? So MDI. So now what is your answer in acute exacerbation of asthma, MDI or nebulization?
But child should be able to tolerate, like
Exactly.
able to use MDI. So it always depends on patient.
Yes. So there is no difference between MDI, DPI, nebulization, and acute asthma. You can try use anything. But if a child is mild to moderate, where he can take MDI, please try to give MDI, because they already use it for that. But in sick children, even with the severe respiratory distress, they cannot take MDI properly. So in the kind of children, we need to go for nebulization preferably. So mild to moderate, try to give MDI itself, and sick severe exacerbation, go for nebulization. So because they are not able to take it properly, MDA. So previously, Gautami answered you had to give with oxygen. So any particular reason for giving oxygen? Does we need to give oxygen for every children, or only for certain category of children?
It
And
will
what is the
worsen the MDI nebulizations will worsen hypoxia, sir.
How?
Because of bronchodilation and
Bronchodilation we needed, na? That's why we give salbutamol.
yes, sir. Sorry.
You want bronchodilation, then how it is going to worsen your hypoxia?
If we give oxygen, we'll resolve the component of pulmonary vasoconstriction.
Pulmonary vasoconstriction. Then definitely it should improve, right? When you give salbutamol, when you have bronchodilation, oxygen flow will be increased, and it should not cause pulmonary vasoconstriction. When you have bronchoconstriction where less oxygen was there, then you should have vasoconstriction. It depends on your VQ mismatch. The VQ mismatch is because not because of increased ventilation. It is because of pulmonary vasodilatation induced by your beta-2 receptors stimulation. Your beta-2 stimulation will cause bronchodilation as well as vasodilatation. So the mainly it was preferentially it was occurred in bronchiolitis children. In bronchiolitis children, the main mechanism is your airway edema, not your smooth muscle constriction. So even infants, even neonates will have beta 2 receptors in the airways. Don't believe that, don't think that they don't have. The classical teaching is they don't have receptors and receptors won't work. It's not like that. Even neonates will have beta 2 agonist receptors in the airway and they will work. But the main pathology in bronchiolitis is not smooth muscle constriction, bronchoconstriction. There the main pathology is mucosal edema and secretions. So that's why your bronchodilation will not work. But the problem here is once you give bronchodilation there, it will go and stimulate the pulmonary vasculature. It will cause vasodilatation. And where you have more airway edema and constriction, and there you don't want to dilate the vessels. Here you should have vasoconstriction so that PQ mismatch will not occur. But by giving salbutamol, you're going to dilate the pulmonary vasculature even in the narrowed airways. So that will cause VQ mismatch. So for that reason, you need to give oxygen to ameliorate these effects. So that's the main reason for giving oxygen with salbutamol nebulization. But if it's MDA, I think we don't need oxygen. And the same principle, MDA is causing bronchodilation when it's not causing hypoxia. I don't think for all asthma children whether you need to try with oxygen, but definitely if the oxygen is available, preferentially you need to give for oxygen driven to ameliorate the effect of hypoxia. There is some amount of VQ mismatch even will be happening acute asthma also, but preferentially it was occurs in bronchiolitis. The mechanism is that one. So what is the role of steroids in asthma? Whether you want to give, don't want to give, and which asthma attacks you want to give steroids?
In every child with asthma, we should give steroids.
Any exacerbation of asthma, the child comes to hospital, child should be on steroids. Even in homes, if the child responded to your initial MDI or initial nebulization and the attack is terminated, child is more comfortable, like very mild exacerbation, you can avoid steroids. But even mild exacerbations in the home also, when you give asthma action plan for the children, what I preferentially write is you start when you start relieving medication, you want more than 1 hour reliever medication, you try to give 1 dose of prednisolone give off. So then you can call the hospital. So that is what I will prefer. Except the very mild attack, all other attacks should have steroids. And when you want to give steroid, timing of steroid, whether you want to give IV or oral steroid,
As early as possible.
exactly. So don't even wait for 1 hour. IV or oral?
Depending upon child condition.
Yeah, if child is able to take orally, oral is as good as IV. There's no like that IV is more absorbable than oral. So the main role of steroids is it speeds the resolution, prevent the relapse. That's all. It's not going to terminate the attack. It just speeds the resolution by decreasing the inflammation and it can prevent the relapse. That's all. So IV steroids to be given, the recommendation of IAP is at the end of first salbutamol dose, as early as possible, and it's at the end of first salbutamol dose you should have given the IV or oral steroid. So oral is as good as IV. And steroid of choice, is there any preference of steroid? We have a lot of steroids. So what is the steroid of choice in asthma?
Hydrocortisone.
Why? Why not prednisolone? Why not dexamethasone?
Short acting, onset of action.
Okay. And others can have, if you IV, others can also have same action. Short acting is not needed for us actually in asthma. You need long acting ones. Actually, the study shows everything is equal. Whether you want to give prednisolone, whether you want to give dexa, whether you want to give MPS, whether you want to hydrocortisone, all are equal. So there is no difference between anything. And coming to dosage, so oral prednisolone need to give for 5 to 7 days. IVR and oral dexa is a shorter duration, 2 to 3 days is enough. So that's why for the compliance will be increased with the dexamethasone, and palatability also good with the dexamethasone. So that's why now many are using dexamethasone ahead of oral prednisolone. And if admission children, you can go for IV MPS or IV hydrocortisone, but the problem is you need to give 8 to 6 hourly doses. You cannot give only single doses. But for dexamethasone, you can give a single dose, even IV. So that is the advantage of dexamethasone. So further course in the ER, actually this is slide is not moving. So this child has worsening of his there's no much improvement in the symptoms. Child had same scoring of 12 to 13 asthma scoring, and his VBG was showing pH of 7.2, PCO2 of 60, and PO2 of 40, bicarb 16, -9 base excess, and 2.2 of lactate. And the next question arises here. Already we given 3 hours of 1 hour of nebulization. We given a steroid, and VBG was showing still respiratory acidosis, and there's not much improvement. So what you want to do next? So at the end of 1 hour, this is the situation of the child. There's not much improvement. Still respiratory acidosis was there. We already completed 3 nebulizations and 1 dose of steroid. So what do you want to do next? Come on, faster. What do you want to do next?
So, magnesium sulfate you can give, sir, over 1 hour.
What route? What is the dose?
IV 50 to 70 mg per kg over 1 hour IV, sir. Infusion.
Okay. Anything else? Only IV magnesium sulfate? Or anything you want to continue or do something?
Continue nebulization, sir. Continue
you have to continue
nebulization.
Exactly. You cannot stop nebulization. You have to continue nebulization, and you need to go for magnesium sulfate. Continuous nebulization of salbutamol is 0.5 mg per kg per hour. So if you don't want to do that thing, you can just remember less than 10 kg, 5, 10 to 20, 10. It's like that you can go on. So the maximum is 20 mg per hour. And magnesium sulfate, you can give IV, and try to give it over half an hour rather than giving over 1 hour, because it will act faster. So it will make an onset of act is like 3 to 4 minutes. So keep giving it faster, and it's very safe. That's what I'm telling. I want to stress one important point from this class is magnesium sulfate is very, very, very safe. Even you can administer magnesium sulfate in peripheral center. Not even in, you will refer for this child for magnesium sulfate. Even in peripheral center, you can administer magnesium sulfate. Only thing you have to monitor when giving magnesium sulfate is for hypotension and respiratory depression. That's all. Nothing else. With the doses of 50 mg per kg, it is not going to alter any other thing. So just keep monitoring hypotension and for respiratory depression. That's all. And it's very, very rare. Less than 1% of children will develop these complications when you give a dosage of 50 mg per kg. So at least try to give 30 mg per kg, you are afraid. And give it over for half an hour, not over 1 hour. So maximum dose is 2 grams, and you can repeat it. If you don't have any response, if you got response, you can repeat it again. And it should be diluted in a minimum 2 times, and give it as an infusion, not as a bolus. That's all. If you are given as a bolus, you can have complications. But if you have give it slowly over half an hour to 1 hour, it will not cause much harm. The side effects I already told: the hypotension, respiratory depression, and muscle weakness. So keep monitoring for your reflexes. So that is what we'll do when you are administering magnesium sulfate for pregnant women. So this child improved gradually over next few hours, and his asthma score came down from 14 to 7. But we repeated a VBG for this child, and this is what the VBG showing. So what do you want to do now with this VBG? The last one is lactate. So with this VBG and with this asthma scoring of 7, and what do you want to do now?
One bolus of normal saline we can give.
Why?
Lactate is high, so maybe.
Yeah, that's what I'm asking. Why lactate was high? When child is improving and hypoxia is getting better, why lactate was high? Yeah, before giving bolus, you need to make sure that you are dealing with shock. So you have to examine and look for what is signs of shock out there. Heart rate is high, BP was low, CRT is prolonged. Just don't blindly treat the VBG with boluses. That's a harmful practice. So never ever treat VBG with a bolus. Treat the child with bolus, not the VBG. If child had signs of shock, giving a bolus is acceptable. This child, the heart rate was 130, from 150 came to 130, pulses are good, BP was normal, CRT was normal. So how to explain this increase in lactate when your vitals are getting stabilized and your oxygen levels are going up, carbon dioxide is going down, and why you are seeing this worsening lactate? Can anyone answer? So there is a metabolic side effect of your beta agonist. This is the metabolic lactic acidosis is a metabolic side effect of your beta agonist. Go and read about the mechanism, how it will cause lactic acidosis. But it is an side effect of your continuous salbutamol nebulization. So there is a high lactate. So if the child is improving here, the first thing I'll do is I'll cut down the salbutamol nebulization. That will going to improve your lactic acidosis. So no need to give bolus for this child. Just you have to come down your salbutamol nebulization. The child is improving, slowly come down and increase the frequency of your nebulization, decrease the frequency of your nebulization. So the next scenario is if the child doesn't improve. Here the child was improved fortunately, but in some conditions the child will not improve even with continuous nebulization, magnesium sulfate. And so what are the options we have here? If child is not improving with your continuous nebulization and magnesium sulfate, so what are the options we have?
Aminophylline infusion, subcutaneous, adrenaline or terbutaline.
Subcutaneous. Why you want to give subcutaneous adrenaline and terbutaline? Already you are giving nebulization. When you already are continuing continuous nebulization, salbutamol nebulization, why you want to go for subcutaneous and adrenaline or IV terbutaline? Is there an extra added advantage by this? Yeah, definitely.
Can it do high drug concentration?
No, even you can get it salbutamol, increase the dose of salbutamol nebulization. The main thing is when you have severe bronchoconstriction, the delivery of the nebulized particles to smaller airways where the pathology is severe will be decreased. Say you have larger airways already constricted and the particles of the nebulized particles are not able to reach the smaller airways. The airway resistance is more in the smaller airways, medium airways actually. So if the larger airways are blocking the drug delivery to the medium and smaller airways, you can give parenteral salbutamol or parenteral thing, so where they can reach the small airways easily and they can improve. This is what the theory proposed for parenteral, because the severe bronchoconstriction is not allowing the drug particles to reach the distal airways. So to open up the distal airways, you can try parenteral terbutaline or now the subcutaneous adrenaline concepts are gone. Once with the arrival of magnesium sulfate, and it was obsolete now. But you can try if you not have magnesium is not working, you can try. And the most recent thing is they're giving magnesium infusion rather than going for these things. There's an option magnesium infusion, 50 mg per kg per hour, for 4 to 6 hours you can try. Rather than going for terbutaline and then aminophylline also, you can continue magnesium infusion. And these are the options we have. So IV magnesium followed by continuous infusion and maintain a magnesium level at less than 4 mg per dl. So that is what now the preferential is. Then you can have IV terbutaline, which is not available in India right now, and some units are procuring it somehow. I don't know how they are procuring it, and majority of the units are not able to get the terbutaline. In Chennai, some centers are still procuring terbutaline, and aminophylline is easily available in our setups. Instead of theophylline, we have aminophylline. The dose is same, 5 mg per kg over 20 minutes, followed by continuous infusion of 0.5 to 1 mg per kg per hour. And this is the options. And you have ketamine. And the next thing is, if child is not improving, you have to go for a non-invasive ventilation, followed by invasive ventilation. And the last option is the same thing. Summary is here. So give the beta agonist 3 times and oral or intravenous corticosteroid, and you go for continuous beta agonist and along with magnesium. And no response, you can go for aminophylline or IV beta agonist terbutaline. Still no response, start on IV ketamine along with non-invasive ventilation. And the last option is intubation with inhaled anesthetics, sevoflurane or in between Helios is there, but it's too costly. So these are the options. This summary of your asthma management from emergency department to intensive care unit. So if you manage the emergency department child very well with whatever protocol we told now with magnesium, early magnesium, I don't think child will go to invasive ventilation at all. The child is going to invasive ventilation means that's a nightmare for intensivist. So we ventilated only twice asthma child in the last 8 years. So that is what your current management protocol changes the intubation rates. So asthma child ventilation is very difficult, and we have to avoid that. So that's why be aggressive in emergency room. Be very aggressive. Keep giving nebulization. Keep giving steroid. Start early magnesium, and definitely it will work. So after introduction of magnesium in the pathway, it has changed the protocol and it has changed the results dramatically. So please be aware of magnesium. It has very less side effects, and don't afraid of giving magnesium in the secondary level units as well. So that is what the main point I want to stress from this talk. And for the fellows and other people who do invasive tertiary care PSU, for their benefit, I am just going to extend this topic further. So what is the main difference between NIV and invasive ventilation in asthma, which is preferable?
Non-invasive always prefers.
So NIV is always preferable over invasive ventilation. Any reason particularly for that? For that thing, we need to move on to what is the problem in asthma exacerbation. The main problem in asthma exacerbation is you have flow limitation, expiratory flow limitation. Because of narrowing of your airways, there is a decreased exhalation of the air, and there is a dynamic hyperinflation of your airways, which will cause all the problems. There's so many problems in the work of breathing, and it affects the cardiovascular system, and it will alter the gas exchange. It will cause hypoxia, hypercapnia. So there's a main pathology. And so for this reason, child will have needs more prolonged expiration, and child should have spontaneous breathing because his rate will be high to sometimes to try the CO2 out. So we cannot adjust that rate and expiratory time by setting our setups. So that's why NIV is more preferential, so that child will have spontaneous breathing. Because of spontaneous breathing, he will adjust his own rate and expiratory time to decrease the dynamic hyperinflation. And so the main goals in mechanical ventilation is you have to minimize the air trapping. If you more air, pump the more air in, and if the air coming out is very less, it will trap the air inside, and it will cause auto PEEP and dynamic hyperinflation of the lungs, which is problematic. And second goal is to prevent the ventilated lung injury. So you need to reduce your plateau pressure less than 28, and you should go for permissive hypercapnia strategies. Even if you have hypoxia like 88 to 90, you should accept. And you should optimize oxygen delivery. Optimization is don't target higher saturations and target only low saturations in asthma ventilation. And the main strategy is you need to overcome the obstruction. So for that, you need to give a high pressure, PEEP, not delta P. You need to go upon your airway pressures. So PEEP should be high with less PEEP so that we can overcome the obstruction during inspiration and we'll pump the air in. So fresh gas will go in, which will cause the gas exchange. And you need to, one more important strategy is to allow the lung to empty. So for that reason, we need to go for short inspiratory times, lower rates. The moment someone see high CO2 in the VBG, everyone will go and increase the rate and the ventilator. That is what commonly we will practice. If the nurse will show VBG of CO2 of 60 or 70, the next moment the resident will do is go upon the rate. Rate is 30, make it 40. So that is not going to work in asthma. The moment if you see high CO2s, you need to drop your rates further. The main important thing is you need to go for more expected time. If you increase the rate, your expected time will go down. So that's why you should not go upon the rates. You have to keep it down. How much low you can keep, that much you can try in asthma ventilation with more expected times. So that is what is going to help your child. So low PEEP, long expected time, short inspirated time, and low respirated. This is a strategy. And is there any role for extrinsic PEEP? We need to give PEEP for in this kind of children. Gautami?
Yes, sir, but less. Like PEEP
Less
should be 1/3 of auto PEEP, like measured auto PEEP.
Yeah, how are you going to help PEEP by giving help PEEP? Because already you have a lot of hyperinflation. So if you're giving PEEP outside, whether it can exhale the air outside, so you are opposing one force. Inside pressure is already, like I said, auto PEEP of 10, and you're giving a pressure of 6 outside. So the difference is 4. But if you don't give auto PEEP, keep a PEEP of 0, the difference is 10. So whether this pressure difference, more pressure difference is going to helpful or less pressure difference is going to helpful. And despite that, you want to give auto some amount of extrinsic PEEP. So what are the advantages of giving extrinsic PEEP when they need it? So this table summarizes your PEEP and the 0 PEEP. So PEEP, some amount of asthma children will have atelectasis due to mucus plugging. So there definitely some amount of extrinsic PEEP is going to help, because your auto PEEP will not going to transmit to that amount of collapsed alveoli, and it can improve oxygenation. And more importantly, there's a concept called splinting of airways. We have more pressure inside the lung, and you want to generate more negative pressure. If you have more positive pressure, to get the air inside the lung, you need to generate more negative pressure. So this is the graph you can see here. So if you have an auto PEEP of 8, you need to generate a negative pressure of -9. From +8 to -9 to make the flow happens. So what it will cause? It will cause collapse of the airways. Like a straw, if you are drinking from a straw and you are sucking too much negative pressure, what will happen to the straw?
Collapse.
Exactly. So that is what will happen in asthma also. When you are you have auto PEEP of more auto PEEP, and you are trying to inhale, the child is trying to inhale more to generate air flow from the atmospheric air to inside the lung. So sometimes airway can collapse. So by applying some amount of external PEEP, you can spin the airways open. That's the main concept. And the most important thing is when you are on NIV or invasive ventilation, you have a trigger. So if you have auto PEEP, the trigger should be like, if you keep even minimal trigger on the ventilator, it will be like very hard for the child to trigger, because the PEEP is already on the high, the pressure inside the alveoli is very high. Already it's not 0, it is +8 or +9. So you need to generate to decrease it to -1, you need to generate -9 negative pressure. So generating a -9 negative pressure is difficult for the child to make the ventilator recognize the child is triggering. But if you give certain amount of auto PEEP, like in example you see here, 8 and 0, the difference is -9. You have to generate -9 pressure to deliver the airflow. But if you apply a PEEP of 6, and the difference is 2, so you have to just generate -3. If you generate -3 negative pressure, the flow begins. So that way it helps in your trigger also. It can increase your trigger sensitivity, so child can trigger easily. And the most important phenomena why the applied PEEP will not affect the flow of air out is water for physiology. So there is a critical point here. You can see one is the P alveolar and the P critical. If your PEEP is not above P critical, there will be no limitation of water flow. That's why if you apply some amount of PEEP also, it will not decrease the air coming out of the lungs. But if you cross the PEEP, like Gautami told, it should be less than 1/3 or half of your auto PEEP. If you go beyond that level, it will crosses the P critical. Once you cross the P critical, the flow will be affected. So that's why you should not go, extrinsic PEEP should not be equal to your auto PEEP. It should be always less than your auto PEEP and should be always less than your critical P critical. So the last slide is the take-home messages. Your asthma severity scores will help in stratifying the severity, will guide the management, and also helps you in treatment assessment response. So always make a habit of scoring your asthma exacerbation in the ER itself. And in severe exacerbations, combine ipratropium. Don't give only salbutamol. The combination will help better. And always try to give your oral IV steroid as early as possible, ideally with the first dose of salbutamol. And go for early magnesium sulfate. It is safer and effective option. And if you want to go for IV drug therapy, apart from nebulization, the first choice is magnesium sulfate now. It's not IV terbutaline or subcutaneous adrenaline or IV aminophylline. The first parenteral choice now is magnesium sulfate. I already posted an article for this in the group. If anyone wants interested, can go read on the article. And other options available are IV aminophylline, IV terbutaline, and IV ketamine. And prefer NIV over invasive ventilation. Allow spontaneous breathing even on mechanical ventilation. And our strategy is low PEEP, high expiratory time, and low respiratory rate. And follow the strategies of permissive hypoxia and permissive hypercapnia. Thank you. If you have any doubts, we'll take. Any questions? Any doubts? If no doubt, we'll end the session. Thank you everyone for attending.